Hello, everyone. My name is Quintin Solano, and I'm a third-year medical student at the University of Michigan. I'd like to thank the wonderful team that I get to work with at the University of Michigan and SAGES for allowing us to present our work on the impact of frailty on ventral hernia repair outcomes in the statewide database. These are our disclosures. Increased patient age has been associated with perioperative morbidity and mortality. More recently, an emphasis has been placed on a patient's fitness for surgery compared to their chronological age. Frailty is defined as a deficit of one's physiologic reserve to withstand stressors and is one way to assess a patient's fitness for surgery. Many tools exist to examine frailty, from physical tests such as the time get up and go or max VO2 max, to the cumulative deficit models such as the modified frailty index. The cumulative model has been shown to hold prognostic value across multiple surgical specialties and allows for large database assessments of patient frailty. Increased frailty has been associated with poor outcomes in the ventral hernia repair population. However, these studies were not able to account for hernia-specific variables known to affect patient outcomes. For instance, frail patients in these studies may have had larger, more complex hernias, making it difficult to discern if their poor outcomes were related to their physical state or the nature of their hernia. Within this context, we sought to answer the question, is preoperative frailty associated with postoperative outcomes in ventral hernia repair patients when accounting for patient, operative, and hernia-specific factors? We retrospectively analyzed a clinically rich statewide hernia database, the Michigan Surgical Quality Collaborative Hernia Registry, which many of you have likely heard of today, and of adult patients who underwent ventral hernia repair between January 2020 and February of 2022. Our primary outcomes were any 30-day postoperative complication and serious complications. Our secondary outcomes included surgical site infection, non-home discharge, and post-discharge adverse events, which were including emergency department visits, readmissions, and reoperations. Patient data included patient demographics, clinical characteristics, comorbidities, and hernia and operative specifics. Our covariate of interest was patient frailty, which was defined using the 5-factor modified frailty index, or the MFI-5. This system assigns 1 point for each of the 5 comorbidities listed here: congestive heart failure, diabetes, COPD or pneumonia within 30 days of the operation, functional status, and hypertension. This index has been validated across multiple surgical specialties, including the ventral hernia repair population itself. Patients were stratified into groups of no, moderate, and severe frailty. 4,400 patients were included in our analysis with a median age of 55 years. 46% were female with a mean BMI of 33. Median hernia size was 2.5 centimeters, and a majority underwent primary mesh repair. 94% of cases had clean wounds, and 58% were performed in the open approach. The distribution of frailty across our cohort is as follows: 47% had no frailty, 36% had moderate frailty, and 17% had severe frailty. On multivariable logistic regression, controlling for patient, operative, and hernia specifics, severe frailty was independently associated with an increased probability of any complication, serious complications, surgical site infection, and adverse post-discharge events. Severe frailty was not associated with non-home discharge in this cohort. This graph demonstrates the predicted probability of any complication across hernia sizes. Here we show that independent of hernia size, compared to those with no frailty or moderate frailty, there's an increased probability of any complication in those with moderate and severe frailty that increases across hernia size. In this analysis, we observed an association with preoperative frailty with postoperative complications independent of one's hernia size. This is important because a seemingly non-complex repair may result in a complex postoperative course for a patient. Frailty was also associated with experiencing a post-discharge adverse event. Therefore, frailty may actually be a predictor of a patient's perioperative trajectory from the immediate postoperative period to days following discharge. So what does this all mean, and what can we do with this data? Frailty screening in the preoperative period can provide an opportunity for preoperative optimization. An example of this is the hernia optimization clinic at our institution. Here, patients are provided with guidance to meet their health needs, such as smoking cessation, weight loss, and activity guidance. Interventions in the preoperative period have been demonstrated to have lasting, positive effects long after the surgery is complete. To highlight how impactful preoperative interventions can be, I want to highlight a study performed by Ryan Howard where he showed that smoking cessation in vascular surgery patients led to nearly 50% of those patients quitting smoking at 1 year. The findings of this study must be interpreted within the context of its limitations. It is an observational study and therefore subject to selection bias, and no causal relationships can be drawn. Long-term follow-up data is not yet available on these patients to report on things like recurrence, which we all very much care about, and collection is currently underway of that data. We only report on clinical outcomes in this cohort. Patient-reported outcomes are also important in the ventral hernia repair population. Finally, frailty score utilized in this analysis only considers the patient's comorbidities and functional status. It does not take into account the physical exam or other measures known to impact patients' frailty and fitness. In conclusion, frailty is associated with postoperative complications. Frailty may be a predictor of a patient's perioperative trajectory, and screening for frailty in the preoperative period offers the surgeon and patient an opportunity to address and optimize deficits to minimize this observed increase for complications. Thank you for your time and attention today. I'm happy to take any questions.